Chapter 64, Alzheimer's and Dementia. First up is differentiating dementia and delirium. Dementia adversely affects the functional ability and the ability to work, fulfill responsibilities, and perform ADLs. It also includes a high risk for injury, impaired nutrition, and social isolation. Dementia is a disorder characterized by a decline in function from a previous level of functioning in one or more cognitive domains. Everything from complex attention, executive function, language, learning and memory, perceptual motor, and even social cognition. As the average lifespan increases, more patients are diagnosed with dementia. Alzheimer's disease is the most common form, accounting for 60 to 80%. In 2018, 5.7 million Americans over the age 65 are living with Alzheimer's disease. And by 2050, this is estimated to increase to up to 14 million. There are many different causes of dementia, everything from neurodegenerative disorders, vascular diseases, toxic metabolic and nutritional diseases, immunologic diseases or infections, systemic diseases, trauma, tumors, ventricular disorders, or drugs. In the case of mixed dementia, this is two or more types of dementia present at the same time, and is characterized by hallmark abnormalities of Alzheimer's disease and another type of dementia, generally vascular. The etiology deals with the normal pressure hydrocephalus. This is a rare disorder caused by meningitis, encephalitis, or head injury. It's characterized by obstruction of the cerebrospinal fluid, leading to a buildup within the brain. Manifestations include dementia, urinary incontinence, and difficulty walking. It's treated with an early diagnosis, as well as a shunt to divert the cerebrospinal fluid away from the brain. Dealing with dementia involves many preventative measures, such as risk factors like hypertension, diabetes, smoking, high cholesterol, and dysrhythmias. And don't forget, with all forms of dementia, Parkinson's, or anything with altered mental status, aspiration pneumonia is going to be a top priority of prevention. Alzheimer's disease. Alzheimer's is a chronic progressive neurodegenerative brain disorder. Often gets used interchangeably with dementia, though it is its own unique form of dementia. And it affects approximately 11% of people over the age of 65, and approximately 1 in 3 people over the age of 85. Early onset Alzheimer's disease is less than or equal to 65 years old, and late onset Alzheimer's disease is greater than 65 years old. While ultimately fatal, death typically occurs 4 to 8 years after diagnosis. It's the 6th leading cause of death in the United States, and it cannot be prevented or cured, only slowing the progression. Brain health is closely linked with the health of the heart and blood vessels. There are many factors that increase the risk of cardiovascular disease. Again, diabetes, hypertension, obesity, high cholesterol, and smoking are your major factors. Diabetes significantly increases the risk of developing Alzheimer's or other dementia. Contributing factors include chronic high levels of insulin and glucose that may be toxic to the brain, insulin resistance that may interfere with the ability to break down the amyloids, and high glucose and cholesterol leading to vascular diseases. Another factor would be head traumas. These are a major risk for dementia. Traumatic brain injury and PTSD have shown an increased risk of Alzheimer's disease or other dementia, affecting a wide range of people from football players and military veterans, or if you remember Muhammad Ali at the Olympics back in the 90s. As part of aging, people develop plaques in the brain. With Alzheimer's disease, there are more plaques in certain parts. Plaques are clusters of insoluble deposits of amyloid or other proteins, as well as remnants of neurons, non-nerve cells like microglia, and other cells such as astrocytes. Here in figure 59-4 from the textbook, we just have a diagram showing the effects of Alzheimer's disease on the brain. This figure compares a normal brain on the left with a brain that has been affected by Alzheimer's on the right. Early warning signs of Alzheimer's disease include memory loss that affects job skills, difficulty performing familiar tasks, problems with language, disorientation to time and place, poor or decreased judgment, and problems with abstract thinking. Other early signs of Alzheimer's disease include misplacing things, changes in mood or behavior, changes in personality, and loss of initiative. For clinical manifestations, the symptoms do not always correlate with abnormal changes in the brain and can be categorized as stages from mild, moderate to severe. They progress beginning with the mild stages and can be highly variable from person to person, ranging from anywhere from 3 to 20 years. The initial symptoms are usually related to changes in the cognitive function, and family members often report to the provider memory loss, mild disorientation, and trouble with words and numbers. As the disease progresses, personal hygiene decreases. They'll show a decline in concentration and attention, unpredictable behavior such as unintentional and uncontrollable agitation and aggression, as well as delusions and hallucinations. Additional cognitive impairments with progression include dysphagia, apraxia, visual agnosia, dysgraphia, and long-term memory loss, such as an inability to recognize family and friends. Other manifestations would include retrogenesis, a process where degenerative changes mirror in reverse order the brain development from birth, meaning personality-wise they're actually becoming more immature. The developmental stages in children compared with deterioration in Alzheimer's disease patients. From figure 59-7 in your text, clock drawing is a simple test that can be used as an assessment technique in dementia. The patient undergoing testing is asked to draw a clock, put in all the numbers, and set the hands at 11:10. In figure A, a clock drawn by a patient with no dementia, while figure B in the middle and clock C in figure C are clocks drawn by people with dementia. Again, there is no cure, unfortunately, as they can only slow the progression. There is no reversing it. Medications do not cure or reverse that progression, and no treatment exists to stop the deterioration of brain cells. Interprofessional care is aimed at controlling undesirable behavior manifestations and providing support for the family caregivers. When dealing with health promotion and prevention, keep your brain healthy and modify risks for developing dementia. Everything from avoiding harmful substances, challenging your mind, regular exercise, staying socially active, and avoiding trauma to the brain. Behavioral problems occur in approximately 90% of patients with Alzheimer's disease. These problems include repetitiveness, asking the same questions, delusions, hallucinations, agitation, and aggression. Sundowning is another unfortunate effect. This is a specific type of agitation. While it has an unclear cause, many do associate it with lack of sleep and disturbances to the circadian rhythm. In this case, the patient becomes more confused and agitated in the late afternoon or evening. It may be due to disturbed circadian rhythms, could also be due to pain, hunger, an unfamiliar environment, medications, lighting, and fragmented sleep. Wandering is another major concern, and it's related to the loss of memory, side effects of medications, physical or emotional needs, curiosity, or stimuli that triggers a memory or earlier routines. You want to observe for precipitating factors or events. Every second counts when someone with Alzheimer's disease is missing. Patients can be registered with a Medical Alert Alzheimer's Association Safe Return form, or even attaching a GPS. Undernutrition is another major problem in moderate and severe stages, including a loss of interest in food, a decreased ability to self-feed, comorbid conditions, as well as long-term care and inadequate assistance that may be a problem. Some methods to help keep their nutrition up, especially when chewing and swallowing become difficult, are to use pureed food, thickening liquids, nutritional supplements, reminding the patient to chew and swallow, as well as offering liquids frequently. You also want to keep it quiet and unhurried environment during meal times, as well as providing easy-to-grip utensils and finger foods for self-feeding. Let's talk delirium. Delirium. Unlike dementia, delirium has a rapid onset, though is reversible, and it is a state of confusion that develops over hours to days, with a presentation that may include a decreased ability to direct focus, sustain, and shift attention and awareness, a deficient memory, orientation, language, visuospatial ability, or perception. They may also show a hypoactivity or hyperactivity. This would be in addition to emotional problems such as fear, depression, euphoria, or being perplexed. It may also coincide with sleep disturbances. In delirium, the symptoms represent a change from baseline and may fluctuate. They also do not occur due to a change in the level of arousal and cannot be explained by another pre-existing, evolving, or established neurocognitive disorder. The exact cause is unknown, with the main contributing factor being an impairment of cerebral oxidative metabolism and multiple neurotransmitter abnormalities, along with pro-inflammatory cytokines that may also be involved. Delirium is rarely caused by a single factor and occurs most often in hospitalized older adults, affecting up to 60%. It's linked to stress, surgeries, and sleep deprivation, with the most commonly being surgical complications. Other contributing factors are pain and depression. They often result of an interaction of the patient's underlying condition with a precipitating event or even a combination of factors. Dementia is a leading risk factor for delirium. Delirium, that risk factor for subsequent development of dementia related to permanent neuronal damage, and there could be many factors that can precipitate the delirium. Many demographic factors could be an age over 65, male gender, as well as cognitive status, dealing with dementia, cognitive impairment, depression, or even a history of delirium. Other factors could be sensory deprivation, sensory overload, visual or hearing impairment, a decreased oral intake, such as dehydration or malnutrition, and many other factors like pain, infection, nutrition, constipation, or lack of hydration, just to name a few. It may also be secondary to medication use, such as sedative hypnotics, opioids, anticholinergic drugs, aminoglycosides, treatment with multiple drugs and polypharmacy, or alcohol and drug abuse, or even the withdrawal from alcohol and drug abuse. Coexisting medical conditions that could act as precipitating factors are severe acute or terminal illness, electrolyte imbalances, chronic kidney or liver disease, history of stroke, neurologic disease, infection, sepsis, fever, or even a fracture or trauma. It also does tend to affect the elderly, as older patients have limited compensatory mechanisms to deal with the physiologic insults and stress, such as hypoxia, hypoglycemia, dehydration. Older patients are often more likely to be treated with multiple drugs as well, making them more susceptible to drug-induced delirium. They may also present with a variety of manifestations, from hypoactive and lethargic to hyperactive, agitated, and hallucinating. Delirium usually develops over a 2 to 3 day period, though can develop within hours. Treatment is important since many cases are potentially reversible. Your role in caring for a patient with delirium include prevention, like identifying high-risk patients, early recognition, eliminating precipitating factors, and treatment to address the underlying causes. For nursing care, we want to protect the patient from harm. Also encourage family members to stay at the bedside, as well as providing familiar objects to help keep them oriented. We also want to provide them a private room whenever possible, or even one near the nurse's station. Also, consistent staffing and reducing any environmental stimuli may also go a long way in reducing symptoms. An interprofessional team may be necessary to address things like polypharmacy, pain, nutrition, elimination, or immobility causing skin breakdown and lack of exercise. The nurse should also focus on supporting the family and caregivers, as caregiver strain is going to be a very major concern here. Medication therapy is reserved for those patients with severe agitation, such as when it interferes with their needed medical therapy, puts the patient at increased risk for falls and injury, and non-pharmacologic interventions have failed. These drugs could take a lot of different forms. Antipsychotic use is controversial, so monitor for side effects closely, though they may be necessary to protect the patient from harm. Drugs we've talked about a lot in our mental health course, like Haldol, Risperdal, Zyprexa, or Seroquel. The patient may be prescribed short-acting benzodiazepines, such as Ativan. And finally, I've got another good wrap-up slide here, just breaking down the difference between delirium and dementia, keeping the patient oriented to time and place, and assessing with that mini-cog test where the patient draws a clock. Also, being very aware of the signs of a stroke, such as slurred speech, facial droop, hemiplegia, and arm drift, as this often leads to long-term disability and severe mental impairment. But anyway, that's all I got for this chapter. I'll see you in the next slides.